Right, so let's begin. We are now at halfway through our paediatric, well, a number of different paediatric webinar events that we've been hosting over the course of this year. And we are extremely delighted to have Dr. Taylor present to us today. So just to tell you a little bit about today, first of all, there is a Q&A function at the top, which will allow you to ask any questions. Please ask throughout. And obviously, as soon as Dr. Taylor is finished, he will look to answer any questions that you have in relation to this. So the recording and the certificate will be sent following the event. So there'll be a certificate of attendance if you need it for your continuous professional development, your CPD points, and that will help you with this session. And we'll send that together with the recording and the presentation slides following the event. So just to quickly introduce, some of you may not have come across INNEG before. Obviously today we are hosting this event with Dr. Taylor presenting. So quick introduction. INNEG, we are a company, we help serious injury and clinical negligence solicitors. We help you accelerate your claim life cycles and reduce unrecoverable costs. So whether you're frustrated, wasting hours trawling Google, phoning secretaries and trying to find the right medical expert, or dealing with vague medical reports or eye-watering fees, or you may be irritated by your pagination and records process. Or lastly, if you're dealing with clinical negligence matters and you're chasing your tail, looking to screen those claims, if any of those issues are things which may concern you, then we should talk. Within INNEG, you get vetted experts with fast turnaround times, management information reporting, and clear, direct communication with one dedicated person. So we're happy to have a chat with you if you think that might be relevant. And if you have an occasional case on your desk that you feel like we might be able to support you with, then do reach out, and we'd be delighted to assist. So moving straight on to the event, we're obviously delighted to have Dr. Taylor here to present to you today. Dr. Taylor is a paediatric neurologist based in Leeds, and he is also a specialist in the treatment of epilepsy, or as we will learn today, epilepsies. And he is considered the leading national voice when it comes to Dravet Syndrome. Lastly, just before we begin, I want to add the webinar is in conjunction with Dravet Syndrome UK, which Dr. Taylor is a big supporter of, and he is running 5K every day during May for this great charity. So I would kindly ask all of you here to consider a charitable donation to Dravet Syndrome UK on Dr. Taylor's page, which we will circulate to you following the event. So without further ado, Dr. Taylor, if I can introduce you, and please take it away.
Hello. Hopefully you can hear me now. My name is Mike Taylor. I'm a paediatric neurologist, as Leo said, and I have two big loves in my life, in work, obviously. First is Dravet syndrome, and the second are headaches. And epilepsy is one of those areas that I'm sure most of you encounter, whether or not a defendant or a claimant firm. So really, it's about what I want to try and do is talk about understanding epilepsy, more importantly, talking about developmental and epileptic encephalopathies, because actually you'd probably be surprised how much you'll encounter this and actually how much you probably actually already know. Then I want to talk about Dravet syndrome specifically, because this month is every day in May, and I think it's a really great time, and it was great that Leo invited me to do this. So a lot of people in the UK with ties to Dravet syndrome are raising lots of money for it. But more importantly, it's a really great epilepsy in terms of it's probably about 10 to 15 years ahead of most of the other developmental and epileptic encephalopathies. So not only is it going to give great examples of where things lie, it's going to give you the landscape of where things are going to evolve. Then we're going to mention about status epilepticus. This is probably one of the big areas, both to understand how the definitions have changed, and more importantly, the medical legal implications. I mentioned about SUDEP. And one of the areas I also think really, I'm very surprised we never see a lot of, but there is definitely scope from a medical legal perspective, and to understand that actually It's a final pathway of a lot of things that you will encounter: infantile epileptic spasm syndrome, or maybe the gateway pathway. And obviously some common pitfalls in medical legal cases. I could probably spend an hour on each of these, but this is a brief introduction. So actually, the first thing says epilepsy doesn't exist. A very bold claim for an epileptologist to make, but actually it's not epilepsy, it's the epilepsies. So you have lots of different conditions make up this term, epilepsy. And I think it's really important to say that we have this significant number of disorders that fall under this banner of the word epilepsy. So it could be you have a child with infantile spasms. You have a different child who has a tumor. You have a child who has a genetic epilepsy, such as Dravet Syndrome, secondary to an SCM1A mutation. They all get that word epilepsy. It comes in so many different flavors. It comes in so many different causes, so many different outcomes, and so many different treatments. Why is that important? Well, not all epilepsies created equally. Some is profoundly difficult to treat. Not all epilepsies are secondary to a brain injury, and some are secondary to a brain injury. And more importantly, not all epilepsy has a good outcome. 80% of people who have epilepsy will succeed with their first two appropriately chosen drugs. After that, you're entering into the world of significantly difficult to treat epilepsy. Some of them will be surgical candidates and as such should be evaluated. When one treatment works for somebody, and it may well be the same treatment that harms another patient, and that's something we're going to come to in Dravet. But talking about one of my big areas of interest, the developmental and epileptic encephalopathies, the best way to describe the most difficult to treat epilepsies. And actually, this is a group of lots of very different epilepsies, and they occur at critical periods of brain development where the EEG changes, the epilepsy changes, have a significant direct impact on behavior, on cognition, on motor regression. It can cause stagnation. It's often associated with drug-resistant seizures, and it can be associated with early death, but it's not always driven by seizures. And it's not always just the seizures causing the issues of development, but the underlying cause can also result in developmental issues. So it's quite a bit of a mix. But what we do as clinicians can also have a direct impact on development, or what we don't do. So that I'm sure many of you are already figuring out, well, these are potential areas where there may be implications for both the ongoing treatment, thinking about quantum. I'm sure many of you are already thinking, well, actually, I've got a case that this might fall into. So this is a very, very old chart. I think probably coming up on at least 10 years old. These are the genetic epilepsies and the different types of epilepsy disorders, and lots of different syndromes. And I'm sure many of you who deal with birth injury claims may be familiar with Lennox-Gastaut syndrome, or may be familiar with infantile spasms or West syndrome, as you sometimes will hear. But there's lots of different syndromes with lots of genetic causes. I always say that when I started training, we had about 25 genes that we knew caused epilepsy, 50 research genes. I gave up counting at the end of 2022 because the gene panels were getting to about 952. I imagine by 2030 we'll be somewhere in the region of 2000. So rather a different world than it was 10, 15 years ago. So for anybody who doesn't know who this lady is, she's just passed away this month, and it's the legendary Professor Charlotte Dravet. Professor Dravet is one of the world's greatest epileptologists, was the world's foremost Dravetologist. And she, in 1978, she described a syndrome called severe myoclonic epilepsy of infancy. and it described one of these really horrendously difficult to treat seizure disorders. People like John Stevenson up in Glasgow had recognised these children who had seizures around the time of their vaccination. There a lot of interest in that, but actually those children now we recognise were part of this underlying diagnosis that in 1989 was renamed Dravet Syndrome. And children with this disorder have a really varied type of seizures. They can focal seizures, generalized tonic-clonic seizures, atypical absence, myoclonic seizures, atonic seizures. So those are the types of seizures. There's lots of types of seizures we treat as clinicians, but these are very classic to this disorder. But Dravet, historically, you would have thought about these children who emerged at the first year of life with these prolonged, what we call hemiclonic, so one-sided jerking seizures. But the clinical field evolves, as with it, where we understand more. So Professor Ingrid Scheffer in Australia published a beautiful paper in 2021 with her colleagues, and it really has expanded that phenotype that we should be watching for. And I think that's really important because I've been about lecturing on behalf of many of my pharmaceutical company colleagues who are really trying to make sure that we know that the phenotypes evolved, and that means that actually that original small description of this epileptic disorder has changed. We now recognise that actually children can present up to 19 months of age. They can present as early as 6 weeks. Fever at the time of onset is very classic. It's really easy. It makes the diagnosis almost a slam dunk in a way, because yes, we have febrile seizures. They're a very common seizure type. They're actually relatively innocuous, but if you see a child with a prolonged febrile seizure at the right age, around the time of vaccination, that's classically how we think of these kids. But actually 55%, so just over half, present with fever, and 3% have never had a seizure induced by fever. We'd always think of that hemiclonic seizure, but actually 50% would present with bilateral, so two-sided tonic-clonic. Not that. So only a third present with a classic phenotype. So many of my very senior, very experienced colleagues, consultant pediatric neurologists for 20 or 30 years, have not appreciated there's been an evolution and an evolving clinical picture, meaning that these children are missed. And that has direct implications. Children are thought as presenting with status epilepticus. We will come to the definition of status epilepticus, but actually only a third of them do. 27% by a quarter have a seizure less than 5 minutes. And usually we see myoclonic seizures, which are brief, subtle jerks, a bit like this, usually by age 2. Why is it important? By Dravet syndrome, they're often drug-resistant, progressive epilepsy. They have a 15-fold increase in SUDEP risk, so sudden unexplained death in epilepsy. 1 in 5 children will not survive childhood. And almost all of them have significant comorbidities, such as autism spectrum condition, ADHD, learning delay. They may end up with movement difficulties or may end up in a crouch gait. But it's not all it's not all SCN1A. So that's the classic gene discovered in 2001. So we're almost 25 years in. We think that now the books say 85%. My colleague, Professor Andreas Bunklas up in Glasgow, would say probably 95, or secondary to an SCN1A mutation. Now, we do know other genes have a Dravet phenotype because it is a clinical diagnosis. It's not a genetic diagnosis. But we now recognize that many of these genes have their own developmental and epileptic encephalopathy, PCDH19, STXBP1 are now being recognized as their own distinct epilepsies. But then there are genes like SCN1B, which have a direct impact on the SCN1A channel in genetic, and as a result, probably contribute to it. there may be subtle differences within the phenotypes described, and as I say, that's resulting in these conditions getting their own diagnoses. But with SCM1A, 4 to 10% are actually inherited from parents, because parents can carry a gene in, say, 20% of their cells. They may well result in that parent having a diagnosis of what we call genetic epilepsy febrile seizure plus. That can complicate the situation because the parent may hold that gene and the child may be delayed as a diagnosis. Oh, they don't have Dravet. Their learning delay can emerge up to the age of 5. But that means that child's been denied the specific treatments for Dravet syndrome. So in the UK, we can only use CBD, so cannabidiol, or fenfluramine for Dravet syndrome, Lennox-Gastaut, or tuberous sclerosis complex. That means that there is delays in diagnoses. But also we know that people with SCM1A mutations can present in very different ways. And whenever it comes to the type of mutation, we have what's called a loss of function or gain of function. And a gain of function mutation will either result in a hemiplegic migraine. So if anybody gets migraines with a weakness in one side, that may be your genetic cause. But for other people who have this gain of function mutation, they can present with a sort of under 6 weeks of age, a neonatal onset epilepsy associated with some movement abnormalities and some contractures. So really important, but more importantly, it comes down to treatment, which I'll come to in a minute. So when it comes to Dravet, there's a little bit of a debate between ourselves and the Americans. So on the left, we have the Americans who like to introduce, we all introduce sodium valproate, which has its own implications with the Medicine, Health and Regulation Authority. In the last year, I'm sure some of you will be dealing with that from a medical-legal perspective. But also, we vary in where we have fenfluramine or CBD within our guidelines. But either way, they're relatively similar. But these drugs are only available when you have a Dravet diagnosis. So failing to diagnose means that we are failing to treat. But more importantly, in Dravet, there's this red box. What to avoid? And there's a set of anti-seizure drugs that work really well for focal epilepsies called the sodium channel blockers. So you can imagine the issue. You have a child who presents with a focal seizure on one side of the body, and you think, I'll start a sodium channel blocker on them, and their seizures get worse. And that's usually because this Dravet syndrome, with its loss of function mutation, they get worse. Well, why is that interesting to you guys? We know that epilepsy management and long-term seizure outcomes, as well as long-term cognitive outcomes, are worse the longer you're on sodium channel blockers. So, failing to recognize the patterns, failing to take heed of the evolving world of genetics, failing to consider that evolving phenotype means you may be actually directly keeping a patient on a sodium channel blocker for years, which may actually have significantly worse neurological outcomes. Well, it's actually known, it's published data. And I've had kids arrive into my clinic who've been on sodium channel blockers for 6-7 years. And when you sit with you do their genetics, you go, they're Dravet, you've got the SCM1A, you pull back their history, and it's a very classic Dravet phenotype. But they've been kept on an inappropriate drug. And by getting them on the right drug, I've been able to get them seizure-free. I've been able to improve their developmental gains. But not to the point that would have been had we avoided 7 years of treatment with the inappropriate therapies. And the thing is with Dravet, we've had decades of genetic experience. We've had decades of a clinical description. This is the epilepsy that's running 10 or 15 years ahead of the others. So this pathway of recognizing what works well, what doesn't work well, the genetics behind it, it's fast approaching. And more importantly, when we come to the point of this condition in its own right, if parents say, well, my child was on the wrong treatment, that may have had a direct implication to their recurrent hospital admissions, their development, there is a definite case to be made. And that's really, really important. And more importantly, over the next coming decades, we're going to see this as a major component of both clinical practice and medical legal practice, because there is going to be a question to be answered. But also, more reasonably, is that was the treatment in keeping with what would have been accepted at the time? Diagnostic difficulties, the original phenotype, it's expanding, it's changing. The access to genetics in the UK is lamentable. At one point in Leeds, our wait time for a routine whole genome sequence was up to 18 months. 18 months of inappropriate treatment. Now, what has revolutionized things is that under 1 year of age, if you have an epilepsy that seems to be genetic, we can now access something called the R14, which is a rapid whole genome sequence, and we can get the result back in 3 weeks. But what if your clinician doesn't decide that, doesn't pursue that route? Are they negligent? Are they in breach of duty? I would argue under age of a year with a new onset epilepsy disorder, actually, yes, they will be, because that would be now standard practice in the UK. Misinterpreting a simple febrile seizure. Oh, it's slightly long. It's, febrile seizures by definition become the word complex over 15 minutes. If you have a few complex febrile seizures, would you be in breach by not considering further investigations? Well, actually, some really great work out of my colleagues in Glasgow again, from Joe Simmons, who's a consultant pediatric neurologist there, would suggest that actually, when you do genetics, and he did this for whole Scotland on the complex febrile seizures, there's actually a huge pickup rate, and the majority are Dravet or an SEM1A mutation, which has direct treatment implications. So failing to consider this, would you be in breach? The answer is yes. The rules are no longer in place with regard to developmental issues. And actually, we should be looking at development. We can't make that call at 2 years of age and deny diagnosis, because developmental issues can plateau as late as the age of 5 years. So yes, it may take a bit longer because development doesn't seem too bad. You're thinking this could be generalized epilepsy, febrile seizure plus, but I'm waiting for development to slow down. Again, you need to keep a really open mind to that diagnosis. Treatment difficulties, as I said, the sodium channel blockers. And more importantly, we are coming into the phase where people are a little bit more reluctant to use sodium valproate because of the impact of the MHRA. I'm going to say that I have plenty of key approaches about Dravet syndrome, about, does this child have Dravet syndrome because their mother or father or mother was on the drug inappropriately. But we're going to have the implication of, well, what if we're not starting valproate in the patient who needs it? And they have suboptimal seizure control and admission to ICU. Children with Dravet can easily have very long seizures, and inappropriate treatment or a lack of treatment may result in an ICU admission, which can cause catastrophic harm. And we'll come to that. As I said, the diagnostic difficulties, you need to know your channel, you need to know the genetics, you need to know the difference between loss and gain of function, because as I described, that gain of function mutation results in a seizure phenotype presenting under 6 weeks of age with a movement disorder. Why is that important? Well, if I just blindly accept this as an SEM1A mutation, and don't question the phenotype, and don't question the type of function, don't put it through. There's really great data packages. Again, the Glasgow team are fantastic at putting these out there. They're not perfect models, but they're prediction models. And if I consider all these elements, which I think are standard practice now for a pediatric neurologist or a pediatrician with an interest in epilepsy in the UK to access, well, actually, I've been denying this child a sodium channel blocker because the gain of function mutation, interestingly, respond very well to a sodium channel blocker. So I've been putting these children on suboptimal treatment. It's very tricky, isn't it? But more importantly, there are direct implications that we would be breaching duty. We would be giving them for treatment, and it would be because we are not doing what is standard practice. So, big things to think about. The medical legal implications. Diagnostics, failure to consider, failure to access the appropriate genetic testing, not considering the wider phenotype, not considering the treatment you have the child on, and then prolonged seizures. And that brings me to this, status epilepticus. So back whenever I was in med school far too many years ago, status epilepticus was you had a 30-minute seizure, that's when you fit status epilepticus. But actually that definition has changed. And actually, status epilepticus is any seizure over 5 minutes. So well, there's a lot more status epilepticus out there than there was by definition. But status epilepticus has a really clear treatment algorithm. And I think that's really important to talk about. We have a set of guidelines as pediatricians, as pediatric neurologists, as adult neurologists, on how we're meant to treat these disorders. If you deviate off it, you better have a good reason, because these have been designed to keep children safe. Now, it might be that you have a child who cannot have a benzodiazepine because their breathing slows down, or they might stop breathing. Now, that might mean you might want to give it home, you'll give it different rescue therapy, but does it mean that you do not give it in the hospital with the supportive and anaesthetist? No, it doesn't. It would be unreasonable practice to completely negate this. It would be a breach of duty to negate that, to refuse to give that treatment because they've stopped breathing whenever they're in a hospital setting. So if you get a child who, first line, you give them formaldehyde, which is a non-benzodiazepine drug, they're still having a seizure, they arrive at the hospital, you give them, say, Keppra, phenobarbital, and they're still seizing, you need to sedate them quickly. You need to be doing what we call rapid sequence induction. You need to be considering your benzodiazepine. You should be giving it, you should be considering midazolam. And failure to do that would be a breach of duty. And depending on how long you take to get that child intubated on infusions, that may well be clinical medical negligence. And why is that important? Well, the longer the seizure occurs, the more likely that damage is going to occur to the brain. Very simple. Let's go with the basics, guys. The longer a seizure happens, the lower the oxygen, the higher the risk of a hypoxic or a low oxygen brain injury. That one you're going to be very familiar with. That's direct causation, direct breach, direct negligence. Then there's the excited toxicity. The longer a seizure occurs, the harder it is to break the cycle. And actually, you find your receptors become less responsive to your benzodiazepines, etc. Then that can induce inflammation, which then further damages brain tissue, further propagates the seizure. You get the neural networks get disrupted. And then the blood-brain barrier breakdown can cause harmful substances to enter the brain and contribute to neurological injury. So we're talking, it needs to be really rapid treatment. It needs to be considered treatment. And more importantly, it needs to follow a reasonable algorithm, and you do not sit there and spend an hour making a decision to intubate a child who's actively seizing in front of you. And I wish I could say that these were medical negligence cases or cases that I have seen in clinical practice, but it's both. I've seen these in both scenarios, and unfortunately, you do sit there and you despair. You say, "Well, what can we do?" Education. People can say, "Well, maybe they weren't aware." This is part of standard APLS algorithm treatment, which we are expected as during our pediatric training, as pediatric neurologists, as general pediatricians, as any doctors to be fully aware of. Anesthetics. So the fact that people don't follow these algorithms or don't consider rapid escalation of treatment in this emergency and life-threatening scenario is somewhat perplexing, but certainly has direct implications. Because if a child who has a Dravet syndrome, they walk, they talk, they go to a special education provision, comes in, has a hypoxic brain injury, and suddenly is left with a movement disorder, wheelchair bound, maybe suddenly going from requiring parents giving a bit of help to full 24-hour-a-day care for a complex movement disorder. Well, that's a very different phenotype to how that child is going to be. And it was directly in response to treatments. And I wish I could say that was rare. I really do. So please keep in mind that, if these families come to you because their child has a really severe epilepsy, just because that's how, the epilepsy is severe, doesn't mean the child came into that hospital in a way that was guaranteed that the outcome was going to be poor. With appropriate treatment, they may have done well. As I said, this is the APLS algorithm. It's published, it's online, it's really easy to follow. It doesn't require much thought. And again, it requires you to think about where your scenarios are in the hospital and a child has a poor respiratory effort. I have plenty of patients who their first line is formaldehyde, and as soon as they're with an ambulance crew or in the hospital and somebody can look after their breathing, we can use benzodiazepine. Sudden unexplained death in epilepsy. 1 in 1,000 people with epilepsy, children and adults, will die unexplained. It may be long seizures, it may be cardiac arrhythmias, it may be respiratory depression, it may be brainstem dysfunction after a seizure. Things we can do is optimize seizure controls, ideal world, supervised sleep, that's not practical, but seizure detection devices. But failing to treat somebody for seizures, failing to recognize seizures, not saying, oh, that funny do is not a seizure, that would be a breach, and that would be directly contributing to SUDEP. Just going back to Dravet syndrome, it has one of the highest mortality rates, 20%. So 1 in 5 will not live through childhood. So it's just really keep that in mind. So infantile spasms, I did have a video linked in. I think the video has been removed. But I know where I'm going to go. I'm just going to I can give a demonstration. That's it. Very simple maneuver. These tend to happen when you're falling asleep and you're awakening. It's a pediatric neurology emergency. Oh, they've got hiccups. Oh, they've got a wee bit of reflux. They're a little bit sicky. Oh, it's just a bit of colic. That's what we hear day in, day out with delayed presentations. The typical age of onset is 3 to 12 months. It's brief spasms. And it's associated with developmental regression. Development goes backwards. At best, you might plateau and has this very chaotic, horrendously dreadful looking EEG. There's no pattern, no rhythm to it. It's called hypsarrhythmia. But there's one line I want to leave you with about it. Time is brain, time is neuron. Delayed in treatment, so is associated with poor outcomes, lower cessation rate, reduced cognitive and motor development, and a greater risk of evolution than Lennox-Gastaut. The earlier the treatment, the higher chance of recovery. And we have a very simple line. 2 weeks. 2 weeks of spasm. So a GP saying, oh, it's just a wee hiccup. A general paediatrician or an A&E doctor saying, oh, this isn't concerning, and delaying that diagnosis will have material contributions to the long-term outcomes. Yes, there may be that the underlying cause of infantile spasms has contributed, but that's not always definitive. And also just to keep in mind, these are sometimes found as part of your birth injury, your hypoglycemic injuries. The number of children who have HIE, who by 6 months have infantile spasm and then evolve into a Lennox-Gastaut or drug-resistant epilepsy. And by drug-resistant, I mean having failed 2 therapies, which were appropriately chosen. So, okay, you may find that this doesn't apply to you, but you have plenty of children who have had a HIE event, and you see this. This could be part of their pathway and will probably indicate they're going to have a much more difficult epilepsy journey. Common pitfalls in epilepsy. Reasonable consideration in differential. What would you expect your GP or general pediatrician to know? The area that you were in the, it's very difficult for everyone to keep up, but these are the things I'd expect people to be aware of, is keeping these things in consideration. GPs, I think GPs should be aware of spasm. I think it's, it's that rare diagnosis, but they can make a significant contribution. I expect a general pediatrician to know exactly what that is. And more importantly, I expect a general pediatrician to have a low threshold to consider further investigation and testing for an epilepsy. We're in the era of genetics. Area where people should be accessing these early, and more importantly, we should be thinking about what the actual treatment implications are. Are we putting the wrong treatments in place? Are we delaying treatments? Was the treatment reasonable or safe? Would a reasonable peer suggest that starting carbamazepine now for focal epilepsy as first line is reasonable? Not really, because actually we have nice guidelines which suggest you need to be starting levetiracetam or lamotrigine. Lamotrigine is not the best drug in the world for Dravet because it's a sodium channel blocker, but levetiracetam, Keppra, very safe drug. Won't make it worse, won't make it much better, but there is a reasonable way to keep that child safe. So you need to be considering the guidelines you're utilizing and you're not practicing old school. We'll start with carbamazepine medicine. We're in the world of advancing treatments. So today I've just had one of my Dravet patients ask me about gene therapy. We're a very exciting phase, and I think again we're looking at genetic treatments. It's really going to be an evolving field. But if we don't diagnose, we're not going to allow those patients to access it early. And deviation from APLS algorithms, that's really important. Second one, access issues. So I've just been on with my surgeons before I came up here about one of my lads who's difficult IV access, no one Dravet, Bristol going into theatre. We know this is a recurrent thing. And the number of times I've had kids put ports in and difficult or access devices, I think it's really, really important that we consider these things. And also emergency management and DGH in the tertiary centre, should they be different? No, because there's APLS algorithms. And if you have a paediatrician with an expertise in epilepsy, they should be competent to have pathways and to come up with reasonable safety nets. But in the end, follow the APLS algorithm, you will keep a child safe. And if you deviate off that very far, that's where a significant breach will occur. And more importantly, the outcome for the patient. Just keeping in mind epilepsy in other cases, because as I say, I could talk about this all day. Some epilepsy start out one way, so you might have a very early infantile epilepsy that evolves to Dravet syndrome, and eventually evolves to Lennox-Gastaut. So you may find, well, why did Dr. Taylor at the age of 2 say this child had Dravet syndrome, but now I've asked to see this child again and they're 12 and they've now got Lennox-Gastaut. Sometimes epilepsy evolves, and be aware that we may say, keep an eye on this case, because actually revisiting things may give you better prognostication. Your neonatal seizures and HIE may well re-emerge later on as an infantile spasm or Dravet syndrome, depending what way you like to refer to it, and then could eventually evolve into that Lennox-Gastaut. So very difficult to make those cases early, and that may have direct impact on the quantum, on what your long-term outcomes are, and what the care needs are in the long term. And the consideration, will the NHS be enough? In the UK and Ireland right now, there are about 170 practicing paediatric neurologists covering about 80 million people. That's not a lot of us. So it's really to keep in mind. There is the private sector, but again, that's still woefully under-resourced. And actually, I'm going to be very honest, a lot of the investigations I do a bit of private work, I can't access to the same way I can in the NHS. It's one of the great things about the institution itself. Just want to mention about post-traumatic epilepsy. I'm sure I've got a lot of defendant firms and a lot of claimant firms pricking their ears up at this one. So first thing, we do recognise genetic factors. There's some really great studies that actually we know people who have family history of epilepsy are more prone to developing post-traumatic epilepsy. Whereas we will probably be coming into a phase in the coming years where we will be seeing the research looking at are there markers that could tell us you're more prone to developing it. I think it's a really exciting phase, and a lot of research and a lot of discussions happening there. Lots of willingness, and I think a lot of financial backing in the coming years. But we also need to think about the underlying background. We are in the phase of genetic epilepsies. A childhood absence epilepsy, and you've had a minor head injury, it doesn't really add up to saying the childhood absence epilepsy was caused by the very minor or very major head injury. It may well be a genetic epilepsy at play. You may have other issues that you have to explore, and I think that's where having a pediatric neurologist look at a case and pull together whether or not there is that clear causation. It's also really, really important to say it's lazy diagnostics to say, oh yeah, has epilepsy, had a head injury, and not consider that wider phenotype. Because one, as a clinician, I could be putting the child on the wrong treatment, but two, I could be directing you as either a claimant firm or a defendant firm the wrong direction. And the other thing just to say is latency. Can you rule it out? Well, actually, latency doesn't automatically rule out an event. It can be well described 10 plus years later, up to 20, depending on the severity of the head injury. You may well have a latency period and there be a relation to the post-traumatic epilepsy. So don't be saying, well, it's 10 years, 15 years down the line, I can automatically rule it out. You can't. But also, you need to take into account every bit of circumstance around that individual as a person. So, conclusion, epilepsy doesn't exist. Diagnosing the DEEs can be difficult. We're in the era of genetics, evolving bespoke treatments. And please, if you do have anybody, even if this is in personal life, that you see who you suspect has an infantile spasm, or you have a client who said, oh, my kid's doing something funny, and it sounds like a spasm, please get them to go to an emergency department immediately. And recognizing epilepsy, it's really, really difficult. It forms part of a wider medical legal picture, and it's often trying to prognosticate can be tricky, but more importantly, if we can define what the epilepsy is, we can give you a much more robust answer about what's happening. So thank you very much, and if open to questions.
Thank you very much, Dr. Taylor. Really appreciate that. It was very, very interesting, I have to say. Just as you're thinking or putting some questions into the chat or the Q&A function at the top, I'd just like to draw all your attention to our next webinar, which will probably be the final edition of our pediatric series of webinars, this time on missed or mismanaged growth plate injuries, presented by Mr. Max Mifsud, paediatric orthopedic surgeon, covering the long-term impact of growth plate injuries. And this will be Tuesday, the 24th of June, again at 1 p.m. So just before, so actually we do have a quick question here. You mentioned we're entering an era of bespoke therapies. So just looking ahead, how do you see that changing the future of expert reports and causation analysis?
So I think the first thing is, as the experts, we're going to be needing to take our time about deciding what is reasonable. Is it reasonable that I expect my district general pediatrician in Wakefield to know about the very bespoke therapy? No, but actually I'm going to expect to get them to me in a reasonable time frame. Then I'm going to look at what are the implications of treatment that I'm directing to, as a clinician as well. I suppose I would say, would I consider that treatment reasonable? Would my peers have been widely accepted? I think within causation reports, we're going to have to be much more measured about what we're thinking. But also, if we are looking at the bespoke treatments, so Dravet syndrome, coming back to Dravet. Well, actually, I would say in the next 5-10 years, if children are entering into getting fenfluramine, stiripentol, or CBD, I think there's going to be questions, unless they've been beautifully controlled in sodium valproate. I do have 2 of them in my cohort who have been beautifully controlled on their first drug, but the rest of them should be availing of these very bespoke treatments. I think even just thinking about neurology is a wider sense. We have a condition called SMA, which is muscle disorder, actually. And children, misdiagnoses of this, the longer you leave it, the more issue you have with the longer term outcomes. We actually have really bespoke treatments. It's about 10, 15 years ahead of even our Dravet Syndrome is an epilepsy, where actually my colleagues are doing gene therapy, doing bespoke treatments that have material contributions. These children are no longer dying, but the longer you leave them, the longer the nerves disintegrate and get worse. So I think it's really, really important that we're getting these very bespoke treatments in early. I think that's where the big thing I'm going to see reports change is, when is it reasonable to have those treatments instituted? And I think the answer is going to be as early as possible.
Thank you very much. Quick question has come through from Ali. Would it be reasonable to delay transfer to hospital during a prolonged fit whilst trying to cannulate? Or if the paramedics were struggling to cannulate, would you advocate just getting the patient to hospital ASAP?
So this comes to a very simple thing. Intraosseous access. If a paramedic crew can do it, brilliant. If they can't, get the child to the hospital. So it comes to treatment algorithms. Well, how many attempts is reasonable at putting a cannula in? Usually the line is 30 seconds to 1 minute. After that, intraosseous access. If you're not able to do that, you need to get that child to a safe environment.
Thank you very much. And I had one myself, actually. And look, for solicitors working on complex paediatric cases, which I imagine is most of the listeners today, what would you say is the most valuable takeaway from today's session, and that you'd like for them to remember?
Just because a child has a complex epilepsy does not mean that their outcome was always going to be poor. If we have delayed anything when it comes to status epilepticus management, if we have delayed treatment appropriately, if we haven't got the IO in, if there's notorious issues of vascular access, if we're not using the appropriate drugs, or if there's a delay in intubation and RSI, there is a clear breach. Sometimes you could have everything done perfectly and they'll still seize. I've got patients who have been through conditions called FIRES, which are febrile infection-related epilepsy syndrome, beautifully, perfectly targeted treatment, and they've still seized for 56 days. That is the rare case. That is the very rare case scenario. The rest of the time, when those gaps happen, that's where the breaches have happened. And I've seen children have delays in their intubation for an hour or two because people aren't sure, or the anesthetists aren't comfortable. They've said, I want to wait until a transport service, but actually they're materially delaying treatment, and actually those children are being exposed to unreasonable conditions for much longer. And that has a direct treatment implication. And more importantly, that will cause the hypoxic injury, the excitotoxicity, the cerebral edema, and the outcomes of that could have been avoided by appropriate treatment.
Thank you very much. No, I really appreciate that. And I don't think there are any more questions just at this point, but obviously, if any of you do have any further questions, then obviously you're able to reach out to Dr. Taylor following with any specific questions. And just lastly, I want to remind you again that Dr. Taylor is running this month for Dravet Syndrome UK. And actually the link for his Just Giving page is on this last slide, which we will circulate following the event. And I'd urge you to please click on it, donate £5, £10, £20, whatever it is that you can do to a great charity and a great cause. And like you say, 150 something kilometers over this month is a pretty good distance. So definitely some value there in terms of this presentation.
Doing a little bit above it, Leo. Just hit 130 miles this morning, so the legs are
the legs are hurting. I'm sure of that. Well, look, I think on behalf of everyone, thank you very, very much for your time today, Dr. Taylor. We really appreciate it. And I think we've all learned something about epilepsy and Dravet syndrome, and we really appreciate your time and wishing everyone a great day. And we will back in touch at the next event very soon. There's quite a few thank yous coming through. So yes, quite a few thank yous coming through from lots of people. So I'm going to now end the event and close the meeting, and like to wish everyone a great day and see you at the next event. Take care for now.